So thank you very much, Jean, for the introduction, and also thank you obviously to Alzheimer Europe and indeed Lilly for organising this symposium, and thanks to all of you for delaying lunch by 45 minutes. Truly grateful. So I'm going to be talking about the EPAD project, and there's, if you like, in your brochure we were asked to put forward 3 learning objectives for these short presentations. And I think the first one's probably the most important in some ways, and I'm going to leave that to the end of this sort of 10-minute presentation, because I think, you know, what we've been doing in EPAD has been exceptionally complicated. It's been hugely ambitious, but it's been very much a journey, and a journey which we were very keen from the outset to make sure that people at risk of dementia, people living with dementia, had their voice heard. And I'm going to illustrate how within the project we hopefully have achieved some of that over the last 2 or 3 years. The next 2 bullet points are, I'm aware that even though I live, breathe, eat EPAD on a moment-by-moment basis, not everybody in the universe actually knows what EPAD is. So I thought I might give you a little bit of a background to the European Prevention of Alzheimer's Dementia project, and how we're innovating to try and bring new and better drug therapies to prevent Alzheimer's dementia. Because everyone in this room, though, will recognize that, at least from a pharmacological perspective, there's been no therapy breakthroughs in the last 20 years. And there's a whole series of different reasons why that may well be the case. And this is a little bit of maybe a slightly complicated slide, but in a sense, what we've been trying to do in EPAD is address concurrently and simultaneously some of those key reasons why drug trials to date have failed to produce anything for a clinician to prescribe. I mean, number one, and I think Mercy was touching on this, is the therapies we've been using to prevent dementia or to modify the course of disease have been given to people possibly too late in the disease course to have a reasonable prospect of success. Number two, if we do go into much earlier disease population, how do we measure whether or not the drugs worked from a clinical perspective or from a biological perspective? Very often, because of the huge unmet clinical need, there's a temptation for the pharmaceutical companies to take early phase development of their drug and rapidly progress it into these huge, large phase 3 studies, maybe without enough learning done in that sort of interim phase that we call phase 2, and that's what EPAD focuses on. And there's also some statistical and possibly some operational elements of some of these trials which have also been suboptimal. So EPAD's going to solve all these problems, clearly, in the way that we've designed the project. And I think we are ambitious and we are optimistic because we're bringing together, I think, some of the greatest minds in Europe and also in the US, Australia and elsewhere to try and address some of these key scientific and methodological issues, both from within industry but also within the pharmaceutical industries. We've got multiple FPA partners, many of whom remain incredibly dedicated to try and find better treatments for Alzheimer's. But of course, right from the get-go, we had Alzheimer's Europe as a partner because of the objective I outlined at the beginning of making sure that we were very much doing everything with the voice of the patient or the person with dementia, key and central to our processes. Now, I'm going to, usually at this point I show about 20 really horrible slides with lines going everywhere and, you know, work packages here, there and everything, and I look across the audience and everyone's going, oh God, hurry up. And that was actually something that we realized with Work Package 6, which Jean-Georges leads on, which is our communication dissemination work package, the way we were communicating what EPAD was suboptimal. It was very technical, it was very academically focused. So we made a video, and I thought it would be easier to explain EPAD through the medium.
Today,
it's
an estimated 36 million people worldwide live with dementia. This figure is set to rise to 115 million by 2050. The most common cause of dementia is Alzheimer's disease, which affects both the connections between brain cells and the brain cells themselves. Eventually, symptoms of dementia appear, which become worse over time. A typical first symptom is memory loss, but inevitably language, The ability to carry out everyday activities and emotions are affected too. But while existing drugs mainly focus on the symptoms of Alzheimer's dementia, researchers are hopeful of finding a cure. Changes in the brain associated with Alzheimer's disease can be detected decades before symptoms appear. Researchers believe that early intervention and prevention before symptoms appear may be a more effective way to tackle the disease. In 2015, dozens of private and academic institutions joined forces to create EPAD, the European Prevention of Alzheimer's Dementia Research Project. EPAD has created a large Europe-wide register of people who are already participating in various national or regional research studies. Thousands will be invited to the EPAD Cohort study for standardized tests and long-term follow-up. Their contributions will help researchers to gain deeper insights into factors that contribute to Alzheimer's dementia and to identify the earliest changes in the brain decades before dementia develops. If an EPAD participant shows early brain changes thought to be related to Alzheimer's disease, he or she may be invited to EPAD's special adaptive clinical trial. Traditional clinical trials typically focus on only one drug. That drug's performance is then compared with an inactive substance, also called a placebo. EPAD's adaptive trials, however, take a more efficient approach. They compare several drugs in parallel against a shared placebo. This way, we can learn much more quickly which treatments are working and which are not. Ineffective drugs can be identified more quickly and removed from the program. New drugs can be added to the trials at any time. Even combinations of drugs can be tested. Participants will be randomly assigned to either a placebo or to one of several new drugs that are being developed to prevent or delay the onset of Alzheimer's dementia. With this approach, EPAD participants have a higher likelihood of receiving an active treatment rather than a placebo. The flexibility and efficiency in the EPAD trial platform is key to finding an effective drug. Today, hope is even stronger. 37 dedicated partners are committed to overcoming Alzheimer's disease. Interested? Visit our website and follow us via Twitter or Facebook to track our developments. Thank you.
So for anyone who's seen my slides before, hopefully realise that's a lot better way of communicating what EPAD is than the slides I often use. One of the things that was mentioned, this is the stage we're at with the project, is we're currently open and recruiting into the cohort study. That's that middle bit, if you like, in that video between the register and the trial itself. Hopefully the trial will start towards maybe this time next year, and that's bang on schedule. The cohort's got about 400 people in it currently, and it has these four principal objectives. It's the readiness for the clinical trial, there's identifying people at risk, as the video said, trying to learn as much as possible about that period before dementia develops from a disease modelling perspective, having data that we can compare with how people do after they start the trial. It's what we call run-in data, so we can look at data over the 2 or 3 years they might be in the cohort, see how that changes once they come into the drug trial. And also making sure that we don't just give these drugs to everybody, but actually target precisely the people who we think are going to benefit most. So how did we actually go about, yes, we made a video, and the video was made with participants who are in other projects that are very closely related to EPAD. But one of the things that we established within Work Package 8, which is our ethics and legal and social implications work package, was what we called our participants panels. And these were based somewhat in projects that I run called Prevent, and also Jose Luis Monievo runs in Barcelona called Alpha. And what we wanted to do was move away from this concept of the research participant as a subject, but actually move them up in terms of their authority to becoming a partner in the project too, at an individual level, ideally. But of course, we will have several thousand people in this cohort study over time, so it'd be impossible to have all several thousand to have their voice heard individually. So what we established was, if you like, a participants panel. And the objectives of that were, as you can see, it was to recognise but also reciprocate the contribution of EPAD participants, research participants, to the value of the project, to ensure a wide range of perspectives were heard. There's about 400 academics and industry folk working in the project, but we have our biases and our legacy issues that we bring to bear. So getting their perspective was crucially important. It's a really tough project, and lots of assessments done, so we need to make sure the research experience was optimised. So the best way to do that is to ask people what their experience was, to improve the design and the documentation, the logistics of how you approach people for the study, how you make sure they stay with the programme, and also to make sure that when we do come up with publications, we've got about a dozen or so already, that we effectively disseminate the academic findings to a variety of different audiences. Each trial delivery centre, apologies for the acronym, the trial delivery centres, the TDCs, are the individual sites where EPAD is running. Each of those will develop what we call an EPAD participant panel, and that EPAD participant panel, the chair, from each of these trial delivery centres will put forward a sort of Europe-wide EPAD participants panel, and then ultimately one person from the EPAD participants panel will be represented in the steering group of the project. This is a work in progress, but that's the eventual aim. The panel roles locally are to provide feedback on study experience, reviewing local study documentation, participant information sheets, for instance, but also acting as an independent liaison for the broader EPAD participant community. Another voice from the Trial Delivery Centre to complement, maybe sometimes even conflict, with the principal investigator and the research team, and that would be encouraged, that would be fantastic. And then centrally, to look at how we run the project across Europe in terms of the cohort protocol, but also maybe the selection of some of the drugs we bring into the trial. The provision of information to participants, including feedback of the results or incidental findings. These are things that can happen quite a lot, and we want to be sensitive to how we manage those things, for instance, brain scanning and the like. But also setting up, with Work Package 6, guidelines about data sharing, sample access, these types of things. Very powerful to have, as an academic, as an industry partner, the voice of the participant heard about how they would like their data, their samples to be used. And often it's much more liberal than sometimes our ethics committees and information governance folk would have us believe. And also recruitment of participants from EPAD into further research studies. So just to finish, penultimate slide, what we're also engaged with our patient organisations through Alzheimer Europe is we obviously have I think we've got a standing invitation to present at this conference, which is great. So we've been doing that, I think, for the last 3 years now, since EPAD developed, but there's also an awful lot of other things that are going into Alzheimer Europe communications, but also locally where I'm from, Scotland, Alzheimer Scotland have been a key partner too, and they've been promoting EPAD locally, and that's true also in Alzheimer's Association AR UK as well. So the patient organisations have been critically important in helping us to communicate and liaise with the public. So my last slide. I mean, EPAD is a hugely ambitious and innovative project, and innovation needs to be linked to participation. It has to be multimodal. We can't just have one person's view or one group's view about what innovation looks like. We have to encourage and encompass the views of many different stakeholders. The framework for collaboration between academics, clinician, industry and research participant is not nice to have. Sometimes there's a sense that, PPI, as we call it in the UK, is a little bit tokenistic. And I think that's so last century. This is now about true engagement and participation. It's not a nice to have, but a need to have. If these projects, these huge projects, are going to be successful, we cannot leave people behind. We had our midterm review a couple of weeks ago in Brussels, and I think we overwhelmed our external reviewers, and they were really bigging us up about the particular impact this project can have if we do it well. Huge responsibility. EPAD could take us to a very fantastic destination in terms of understanding disease before dementia and also developing new treatments. But we have to be on this journey together. This isn't one person or one institution's or one drug company's journey. This is all of our journey. And that's why we're desperately keen to make sure that the participants' voice is very clearly heard. So I will stop there. Thank you.